In practice, insulin-resistant patients, those with type 2 diabetes or metabolic liver disease, frequently present with low-density lipoprotein cholesterol levels perfectly aligned with standard guidelines. Yet these exact patients continue to suffer myocardial infarctions and ischemic strokes at alarming rates. The discrepancy lies in the metric itself. LDL-C measures the total mass of cholesterol carried in the blood. It does not measure the physical number of particles transporting that mass. When assessing atherogenic risk in metabolic syndrome, relying solely on total mass is an incomplete calculation. To quantify the actual burden, clinicians evaluate apolipoprotein B. Rather than weighing the internal cholesterol cargo, an ApoB assay provides an exact head count of the circulating atherogenic particles. Reconciling this discordance between mass and count is how we target residual cardiovascular risk. Applying this logic beyond the coronary arteries, however, requires us to rigorously stratify the evidence across different organ systems. This diagram illustrates the core stoichiometry of plasma lipoproteins. Every single LDL, intermediate density, very low density, and lipoprotein A particle carries exactly one molecule of apoprotein B. When a patient develops insulin resistance, their hepatic VLDL secretion increases significantly. The baseline particle count surges. Through a process of CETP-mediated lipid exchange and hepatic lipase trimming, these new particles are stripped of their internal cholesterol cargo. This leaves behind a dense cluster of small cholesterol-depleted LDL. The internal mass drops, but the physical number of ApoB surface tags remains dangerously high. Because the average cholesterol payload per particle is lower in these patients, achieving the same LDL-C mass requires a drastically higher total number of physical particles. This stoichiometric reality mathematically proves why mass and count diverge. In diabetic and obese populations, measuring ApoB yields a far more accurate assessment of atherogenic burden than LDL-C. Atherosclerosis begins when these ApoB-containing particles cross the endothelium and become trapped in the subendothelial matrix of the arterial wall. This is the response to retention mechanism. The trapping occurs through ionic binding. Positively charged residues on the ApoB100 molecule lock on to negatively charged glycosaminoglycans located deep within the arterial matrix. Once immobilized, the particles oxidize. This local oxidation triggers a massive immune response, driving macrophages into the area where they engorge on the trapped lipids and form foam cells. These foam cells activate the NLRP3 inflammasome, a multi-protein complex that initiates cellular inflammation, accelerates plaque progression, and degrades the vascular structure. This sequence definitively causes coronary atherosclerosis. The critical task for the clinical field is to evaluate whether this exact mechanism applies with the same certainty to non-coronary vascular beds and extracardiac organs. This chart outlines a 4-tier evidence ladder designed to prevent clinical overgeneralization. Tier A requires Mendelian randomization paired with randomized controlled trials to prove causality and outcome reduction. Ischemic stroke and peripheral artery disease sit confidently at this top tier. Megastroke Mendelian randomization confirms lifetime genetic exposure to lower ApoB causally reduces large artery ischemic stroke. Trial data from Fourier and Odyssey verifies this. Aggressive lowering of ApoB with PCSK9 inhibitors proportionally reduces stroke occurrence without increasing hemorrhagic stroke rates, even at extremely low lipid levels. The CLEAR Outcomes trial and the Fourier peripheral artery disease subgroups confirm this identical causal relationship extends to the lower extremities, severely reducing major adverse limb events. For large artery stroke and peripheral artery disease, the ApoB mechanism unequivocally drives hard clinical outcomes. Aggressive lipid-lowering therapies in these specific diseases are justified by verified data. Moving down to Tier B, we find conditions where the biological causality is proven, but definitive disease-specific outcome trials remain pending. We categorized calcific aortic valve stenosis here. This specific valvular disease is driven uniquely by lipoprotein A. Unlike standard LDL, the LPA particle carries oxidized phospholipids that initiate localized valvular calcification entirely independent of LDL-C. Mendelian randomization robustly identifies LPA as the dominant heritable driver of this stenosis. Several targeted therapies, including antisense oligonucleotides and siRNAs, are currently in advanced stages of development, but completed Phase 3 outcomes data for these drugs do not yet exist. The per-particle pathobiology is sound, but until trials like LPSA Horizon conclude, treating valvular stenosis by lowering LPSA relies heavily on extrapolation from standard coronary disease models. Tier C isolates metabolic and renal conditions. Here, ApoB acts as a highly reliable predictive biomarker, but the causal pathways are deeply entangled. In metabolic dysfunction-associated steatotic liver disease and chronic kidney disease, ApoB drastically outperforms LDL-C in predicting secondary cardiovascular events. The genetics highlight this complexity. Specific PNLA3 variants successfully reduce the liver secretion of ApoB, lowering circulating levels. Paradoxically, this exact mechanism increases intrahepatic lipid accumulation and accelerates liver disease progression. In chronic kidney disease, impaired remnant clearance produces uremic dyslipidemia, severely elevating ApoB. Yet, while the SHARP trial proved lipid lowering reduces events in early kidney disease, the cardiovascular benefits attenuate completely once patients progress to end-stage dialysis. ApoB is an indispensable metric for tracking comorbid risk in these patients. It is not, however, the linear cause of the underlying hepatic or renal failure itself. Tier D is the bottom of the ladder. This tier captures hypothesis-generating associations, where the clinical evidence is restricted entirely to mechanistic plausibility and observational signals. Multivariable Mendelian randomization occasionally links elevated ApoB to dementia. However, that signal is unstable, highly sensitive to model specification, and heavily confounded by other genetic risk factors like ApoE-epsilon-4. Similarly, LPA possesses antifibrinolytic properties that theoretically could drive venous thromboembolism, but the relationship lacks consistent genetic establishment. In oncology, studies linking low ApoB to higher risks of certain cancers largely reflect reverse causation. Preclinical malignancies often lower circulating cholesterol long before a formal cancer diagnosis occurs. Aggressively lowering lipids to treat Tier D conditions assumes pleiotropic effects that current data simply does not support. Intervening here based solely on mechanistic theory is therapeutic overreach. Translating this hierarchy into clinical practice requires understanding exactly what drives atherogenic risk in cases of mixed dyslipidemia and hypertriglyceridemia. This visual comparison contrasts the outcomes of two major trials. REDUCE-IT demonstrated a 25% reduction in cardiovascular events using high-dose icosapent ethyl. The PROMINENT trial, testing pemafibrate, effectively lowered triglycerides, but yielded no event reduction whatsoever, while ApoB remained persistently elevated. Pemafibrate succeeded in lowering the circulating triglyceride mass. It failed entirely to lower the physical count of ApoB-containing particles. Remnant-rich lipoproteins infiltrate the arterial wall and drive atherosclerosis because they are ApoB-bearing particles, not simply because they carry a high volume of triglyceride cargo. If a therapeutic intervention lowers triglycerides but fails to reduce the actual ApoB particle count, the cardiovascular risk remains intact. This exact evidence stratification guides the modern clinical consensus established by the 2026 ACC-AHA and the 2025 ESC-EAS dyslipidemia guidelines. Universal ApoB screening of all adults is not endorsed. Selective testing is strictly reserved for evaluating residual risk in patients with metabolic syndrome, diabetes, and discordant lipid phenotypes. The sequential treatment protocol begins by aggressively optimizing the primary LDL-C target using high-intensity statins. For very high-risk patients who fail to reach these targets, the sequence escalates. Clinicians must add ezetimibe, followed by PCSK9 monoclonal antibodies to forcefully reduce the remaining particle burden. Furthermore, current guidance demands that lipoprotein A be measured at least once in every adult's lifetime to identify hidden inherited cardiovascular risk that standard panels miss. The biology is precise. clinicians must measure the actual atherogenic particle count, identify patients with mass-to-count discordance, and deploy lipid-lowering therapies only where the clinical trial data proves a reduction